By now. Welcome everyone to today's webinar on the management and self-management of endometriosis, hosted by the Victorian Women's Health Services. I'd like to begin by acknowledging that we're meeting on Aboriginal lands, and for me that is the land of the Wurundjeri people of the Kulin Nations, who are the traditional owners and custodians of the land from which I'm speaking to you today. And we pay our respects to elders past and present, and I'd like to also extend this acknowledgement to any Aboriginal or Torres Strait Islander people in attendance today. My name is Laura Riccardi. I'm a Health Promotion Officer at Women's Health East, and I'll be chairing today's webinar. I'd like to extend a warm welcome to all attendees here today. And before I introduce our notable guest speaker, I'd also like to acknowledge the work in particular of Women's Health in the Southeast and their Health Promotion Officer, Jess Ellsworth, for her efforts in coordinating today's webinar, which has been organised in recognition of the fact that it is in fact Endo March, a month devoted to advocacy and awareness of endometriosis. And this is an important question for the Victorian Women's Health Services, not only because sexual and reproductive health and rights for women are one of our strategic priorities, but also because it has broader physical, mental and social well-being and health implications for women and for gender equity. So endometriosis, as I'm sure most of you are aware, is a common reproductive health issue that affects at least 200,000 Victorians, or around 10% of women and people who menstruate. And it's associated with chronic pain, irregular or abnormal menstruation, infertility, and can have really significant long-term impacts on women's mental health, their social health, their intimate relationships, their educational outcomes, and their participation in employment. It gives me great pleasure to introduce our speaker, Dr. Beck O'Hara, who will be expanding on some of these points on the implications of endometriosis for women's health today, and also the self-management of the condition for women. Our speaker is Dr. Beck O'Hara. Beck is a grant-funded researcher with the Robinson Research Institute at Adelaide Medical School. She's currently working on the Endometriosis Digital Health Platform project funded by Jean Hales for Women's Health and the Australian Government Department of Health. And she has more than 10 years experience in chronic disease, health policy and health promotion research at both a state and local government level, at not-for-profit institutions and at universities. Beck is experienced in both qualitative and quantitative research methods, and today she'll be presenting her research from her PhD at Monash University, where she conducted a mixed methods study examining women's experiences of managing endometriosis in Australia. Just before Beck kicks off, we will be recording this session today, and I'll just remind everyone that because it is a webinar, we can't see you, you can only see us, so your faces won't appear in the recording, and it will be circulated by our host Jess in the next day or two, along with an evaluation, which we do request that you complete as soon as possible, please. Unfortunately, we don't have an opportunity to ask Dr. Beck O'Hara questions today due to time constraints, but if you have any questions regarding the presentation or her research, please include them in your evaluation response and Jess will pass them on to Beck. So I'll invite Dr. Beck O'Hara to take over the presentation. Thank you very much, Beck.
Thanks, Laura. So thank you for inviting me to present today on my PhD research examining endometriosis management in Australia. As mentioned, this research was undertaken whilst I was at Monash University. So endometriosis is a chronic inflammatory disease that's characterized by endometrial-like tissue that's found in places outside of the uterus. And we don't really know what causes endometriosis at this stage. We do have several theories, and they include retrograde menstruation, so that backflow of menstrual blood through the fallopian tubes, genetic influences, or the disease being related to some kind of immune response. But none of these theories have been entirely proven. And endometriosis can be associated with a range of symptoms, including pain with menstruation, chronic pelvic pain, and fertility problems, to name a few. We know that symptoms are quite variable between people, and some people may not experience pain with their disease. The severity of symptoms is not associated with the extent of the disease. So what we mean by that is someone can have quite minimal disease, but experience a lot of symptoms. At present, there is no cure, so long-term management is required. And management really focuses on just reducing those symptoms through surgical intervention, so trying to remove those lesions, and medical intervention, so using pain medications or hormonal treatments to help with symptom management. And we know that some people may also seek treatment from complementary and alternative practitioners. So a little bit of background, the type of research I do can best be described as psychosocial research. So I ask people what they think, feel, or experience about a particular topic. So I'm not a clinician or based in a lab. I do research in the community. And prior to undertaking my PhD, I'd worked for 10 years in chronic disease research, health policy, program design, and health evaluation. So when I first considered a PhD in this field, I'd planned to create a health education program for people with endometriosis, as I could see many similarities between managing other long-term conditions and this condition. However, when I investigated further, I realized there remained way too many unanswered questions about how people manage their disease. And there was a lack of national data that could really provide insight into the development of this sort of program. So I had to take a step back and begin with a broader question. So the overall aim of the project was to explore how endometriosis is managed in Australia. And it was hoped that this information could inform clinical practice guidelines, health policies, and education programs for people with endo and those that support them. The study did feature multiple components, but I just wanted to share with you the results from the survey and interviews. So this is an overview of the study design. And so that we could compare our findings to international studies that had already been conducted, we used the same selection criteria. So women were aged 18 and over, living in Australia, who could communicate in English and reported a surgical diagnosis of endometriosis. Now, using this criteria means that the findings from this study might not represent all people's experiences with the disease in Australia, for example, those under 18 years of age, which is a limitation. The study, however, was supported by an extensive marketing strategy to ensure that people from across Australia and with different experiences of endometriosis had an opportunity to have their say. Now, we wanted to capture experiences from those that might be newly diagnosed right through to those that have lived with the condition for a long time. We had 620 participants that were aged 18 to 71 years complete our survey. And after completing the survey, participants had the opportunity to opt in to be contacted about interviews. Now, I had 420 people register for an interview, but obviously I couldn't interview everybody. So we recruited a diverse sample of participants based on age, length of time since diagnosis, education, and geographic region. And I interviewed 15 people. So the survey ran from November 2017 to January 2018. We had 620 responses, and the average age of those respondents were 34.6 years. Nearly half of the sample were university educated, and the majority were employed and Australian born. So I'd ask participants to provide their residential postcode, and we do this so that we can ensure that we're getting representation from across Australia. Now, the markers on the map represent postcodes, so obviously more than one respondent can live in that postcode, and sometimes the markers overlap. So the marker in the Northern Territory actually represents 3 bordering postcodes. So you can see there was representation in our survey from each state, with obviously a greater concentration along the eastern seaboard. So people might experience different symptoms depending on the different stage of their life. And that obviously influences the answers to the rest of the questions on the survey. So we needed to ask whether they'd experienced a period in the last 3 months because they might have an increase in symptoms during this time, whether they were pregnant, or whether they'd gone through menopause. So for our survey, almost 70% had a period in the last 3 months, a small minority were pregnant, and around 10% had gone through menopause. So participants were asked what age they were when they were surgically diagnosed with endometriosis. And in our study, the average age was 26.7 years, but that did range from as young as 12 years through to 54 years. I then calculated how long they'd been living with that diagnosis, and the average years since diagnosis was around 8 years, but it ranged from very newly diagnosed through to those that have been living with the diagnosis for 46 years. Diagnosis delay is a common calculation in endometriosis research, and we use the same formula that's been used in international studies. So you ask your participants what symptoms they experienced and what age they started, and then you take an average of that age range, and then we subtract that from the age of diagnosis. So the average diagnosis delay for participants in this study was 6.4 years. And this is consistent with the multi-country studies that you can see on the slide. Participants were asked to indicate which symptoms they had experienced from a long list of symptoms, and the top 5 were pelvic pain, fatigue, painful periods, bowel upset, so constipation or diarrhea, and abdominal bloating, or what we call in the community endobelly. Respondents were also asked whether they'd experienced pain at different times in the last 3 months. So over 60% of the sample indicated they experienced pain with their period or with intercourse, and the majority had experienced pain at other times, and we call this chronic pelvic pain. So because pelvic pain is quite a common symptom of endometriosis, we asked participants to rate their pelvic pain on average and then at its worst. And we used the scale where 0 is no pain and 10 is the worst possible pain that you could experience. And I've provided the average values for the pelvic pain ratings, but you can see that we did capture those that experienced no pain through to those that did experience that significant level of pain. We also asked how many times they'd had a range of different surgical procedures, and the results on the slide show the average number of laparoscopies, so that's keyhole surgery, and laparotomies, so open abdominal surgery, that participants had undergone specifically for their endometriosis. Some have had both types of surgery, whilst others were diagnosed incidentally during other surgical procedures, such as having their appendix or gallbladder surgeries. Now, we had a slightly higher average number of surgeries in our sample when we compared it to the international studies, but this is probably a reflection of the slightly older age profile that we had in our study. We were interested in the types of medical management that people were using. So 60% of the participants had used some form of hormonal treatment in the last 3 months. And among those that did use this type of treatment, the pill and the IUD were the most commonly used. Almost half of the participants had used pain medications that were prescribed by their doctor, and we asked participants to indicate which medications they were using. So the larger the text in the word cloud, the greater number of times that was reported. So you can see things like endone, Panadine Forte, and Tramadol were the most commonly prescribed, and these are all opioid medications. The majority of the participants had also used over-the-counter pain medications to assist with managing their pain of endometriosis. And it's important to note that this survey was conducted prior to the need for a prescription for codeine-based products. So I've circled those products in the word cloud because they were quite popular as well for managing pain. I'm also interested in the role that individuals might play themselves in managing the condition. So I included a question of some common self-care activities that someone might use to help them manage symptoms. And the chart here presents the most frequently reported. So the most common methods include applying a heat pack or undertaking exercise. So due to the ongoing nature of endometriosis, I wanted to examine what sort of health services were being accessed by participants in Australia. We asked participants to indicate if they'd seen any of the listed health practitioners for their endometriosis and the number of times they'd accessed these professionals in the last 12 months. So, not surprisingly, most participants had indicated they'd seen a GP or a gynecologist in the last 12 months. But of interest, over a quarter of respondents had seen an emergency department doctor, with an average of 3 visits in the last 12 months. Now, when we were speaking to people during the interviews, we found that this was because they had difficulty getting their pain under control. So they presented to the emergency department. Other specialists were also accessed by a small group of respondents, including gastroenterologists, pain specialists, colorectal surgeons, and neurologists. We were interested in their use of allied health services, so we asked them to indicate if they'd seen any listed allied health professionals. Almost a third had accessed a mental health practitioner, so it was something like a psychologist or counselor, and a quarter had accessed a physiotherapist specifically for their endometriosis. We also asked about the use of various complementary therapies, so you can see that a quarter had accessed a massage therapist. Something that we found interesting was that the complementary therapies tended to be accessed slightly more frequently than some of the gynecological and GP services. So this survey highlights that participants experienced a broad range of symptoms, and this can obviously affect their work, emotional well-being, family, and social life. There was a 6.4-year average delay in diagnosis, and that's consistent with research in other countries. But it does highlight that there is a substantial amount of time that people are dealing with these symptoms without a diagnosis. The majority of the participants also reported using pain medications, particularly those obtained over the counter. And it highlighted that participants may be affected by the new prescription requirements for different pain medications. The results also highlight that a range of practitioners are being accessed, and often this required repeated visits to assist participants to manage their symptoms. These visits obviously have financial implications for people with the condition, but it also might affect their work, family, and social life, as individuals have to take time out to attend these appointments. So I also conducted interviews as part of this study, which allowed me to gain insight into the day-to-day experiences of managing endometriosis and really to investigate that role of self-management. So when we think about a chronic disease, say something like diabetes, we often recognize that self-management plays a component in the effective management of this disease. So self-management is the active participation of the person in planning, decision-making, and tasks to manage the symptoms, treatment, physical, and psychosocial changes that is involved in living with a chronic condition. Now, the chronic disease literature highlights a number of components of self-management, and I've just popped those in a diagram. In other diseases, we know that self-management programs have been associated with improvements in participants' knowledge about their disease, self-efficacy, performance of self-management tasks, and some aspects of health status. So having worked in that chronic disease space, I wondered if self-management might play a role in the effective management of this disease. So I wanted to give you a bit of context from the qualitative study and just wanted to provide you an overview of the participants. You'll notice some speech bubbles throughout the rest of the presentation, which are direct quotes from some of the participants in the study. And I like sharing these because it's better to hear it in their own words, and it's a good way to sort of share their experiences with you all. So among the 15 participants that completed an interview, the average diagnosis age was around 27 years. And I spoke to those that have been newly diagnosed through to those that have been living with the diagnosis for some time. Now, in terms of diagnosis, participants' experiences really varied. Some presented to various GPs with severe pain. For others, investigations started due to difficulty conceiving, or there were some that were diagnosed during other surgeries. I guess one of the things that really struck me when doing this type of research was just how variable symptoms were between participants. Some people self-described their case as quite mild, experiencing pain only with the first few days of their period, whilst others experienced pain every day. And for one lady, the first time she experienced symptoms was when she had her lung collapse in her 50s, and that later led to a diagnosis of endometriosis on the lungs. Participants highlighted that they used many approaches when managing endometriosis. They reported that managing endometriosis is not just about managing those symptoms, but also recovery from surgery and managing any side effects from hormonal treatments and pain medications. These are just two examples of some of the treatment side effects that participants reported during their interviews. They included things like weight gain, mood disturbances, and increased pain. So one theme, perceptions of control, was a major theme from the interviews. It relates to how participants with the disease sought to control their symptoms through medical, surgical, complementary, and self-management approaches. Now, experiences of control varied between participants, so some felt that they had control to an extent over their symptoms, and self-care tasks, those activities or tasks they do themselves, were seen to help some control their symptoms. So this might include things like changing their diet, for example. Whilst others felt that due to the very nature of the disease, it was completely beyond their control. There was not a lot they could do about it. And perceptions of control seem to vary over time. So for example, a participant had a surgery a couple of days before she did her interview. And at that surgery, the surgeon confirmed that the current treatment was working and the disease had not progressed. The participant reflected that at that moment, she felt that she was now in control of the disease. But she recognized that if I'd asked her a month or so ago when her symptoms were really bad, she wouldn't have felt that she had much control or confidence to manage the condition. So many of the components of self-management were discussed in the interviews. Self-care was the most common element of self-management that participants discussed. And it's also what came to mind when I asked people to describe what they thought self-management meant to them. So this included things like altering their diet, undertaking exercise, using heat, meditation, relaxation exercises in order to help them control their symptoms and cope with the disease. However, as people were going through their interview and discussing their experiences of managing the disease, many more elements of self-management were discussed, which you can see in the diagram. So today we'll focus on the themes related to being a partner in care, body literacy, and experiences with health professionals. So being an active participant in decision-making is one core aspect of self-management. And the extent that participants were active decision makers really varied depending on their circumstances. Participants spoke of times where they felt pressured to take various medical treatments to manage their symptoms. For some, this happened when they were younger or when they felt like they really couldn't question medical advice, or when they were first diagnosed and they really didn't know that much about the disease. For some participants, bad experiences with medication or surgery prompted them to take a more active role in decision-making. So for them, that involved researching potential treatments, asking others with the disease for their experiences, and listening to their bodies. So few participants reported formally monitoring their symptoms, which is something that we would usually associate with managing a chronic disease. Rather, they spoke of being in tune with their bodies and having a sort of body awareness. For some, this is what prompted them to seek medical advice in order to obtain a diagnosis. For others, it was a way to evaluate whether a particular medical treatment was working, or it prompted them to undertake those self-care tasks to help them manage their symptoms. It also motivated them to follow up with medical providers if their symptoms progressed or changed over time. So a key aspect of self-management is really having a positive patient-provider partnership. Now, 14 of the 15 participants described some negative experiences that they'd had with health professionals, including being dismissed or a lack of endometriosis knowledge amongst these professionals. Participants described needing to try multiple health professionals, including GPs and gynecologists, until they found that one that they felt like they could work with. They often relied on recommendations from other people with endometriosis, particularly when trying to find a specialist. Once participants had found that person and they were telling me about their positive experiences, they highlighted that they felt they were being listened to, they were provided information and treatment options, and they felt like they actually had a say in decisions around treatment. Participants spoke of a number of barriers to self-management. They described the condition as pervasive, taking over their life, affecting everything in their lives, such as work, social life, fertility, personal relationships, which made the condition very difficult to manage. Two barriers that I'd like to focus on are the mental and emotional challenges of the disease and barriers to managing endometriosis in a rural and remote setting. So participants described endometriosis as a mentally and emotionally challenging disease. Some people described periods of depression or anxiety arising from their condition, and this was particularly in relation to their experiences of pain. For some, the hormonal treatments that they used to manage the disease also contributed to their anxiety and depression. A few spoke of talking to a psychologist, mental health nurse, or counselor about their experiences. Some participants explained that endometriosis was an isolating disease, and this was particularly among those that were in the older age group, as period pain was just not discussed. Some younger people also experienced these feelings of isolation, particularly when they were initially diagnosed. Support groups, often through social media, helped to provide some with support and understanding from others that were going through the same experience. So having lived in a remote town myself, I really wanted to capture the experiences of people from these areas in my study. Costs of treatment, lack of access to specialists and allied health staff, and lack of family support, as their families lived thousands of kilometers away or interstate, were just some of the major barriers that participants faced in these regions. Those living in regional and remote areas often had to travel to major cities to receive care, as there were just no available specialists where they lived. For some, this meant taking time off work, flying interstate, coordinating their surgeries, tests, and any fertility treatments whilst they were in these major cities. Access to GPs who understood this condition was also challenging for those living in these regions. So this study highlighted that endometriosis is a chronic condition that may require multidisciplinary care. There's a need for recognition that endometriosis isn't just a physical disease, but has an emotional element that may require support through mental health providers. Upskilling health providers in endometriosis is required, particularly in regional and remote locations where specialist staff are lacking. Providers need to take into account people's experiences and to work jointly to develop a management plan. Now in Australia, GPs have the opportunity to develop a tailored plan to assist with coordination of care for people with chronic disease. These are known as chronic disease management plans. They can also add a team care arrangement that provides someone with a chronic disease access to 5 subsidized allied health services. Now, this might be a useful mechanism to assist with coordination of care for people with endometriosis that continue to experience ongoing symptoms. So how do we support someone with endometriosis? We know that period pain is often normalized, both at an individual level, societal level, and amongst some practitioners. It's important that we start having conversations about periods with our young people so that we can make this topic less taboo. If you're a healthcare provider, asking a question about any symptoms that the patient experiences with their period is a good start. A useful tool that can be used is the RATE online tool developed by RANZCOG to identify and assess endometriosis. To support self-management, we really need to be promoting active engagement of the person in their care. So simple things like asking the patient what their goals are and incorporating them into a chronic disease management plan. Encouraging them to track their symptoms, and Quendo has a magnificent app for that, which you can see on the slide. Encouraging them to bring a support person to their appointments and providing resources so they can educate themselves about the disease and connect with others that are experiencing the same thing. So if you're looking to upskill in this area, RANZCOG have an online e-learning module and the Australian College of Nursing have an endometriosis and pelvic pain unit for nurses. The Australian associations listed on the slide have a great selection of resources, including videos and podcasts, Facebook groups, fundraising and education events for people with endo and those that support them. I'd just like to acknowledge the people who participated in this research, my supervisory team, and my funding sources.
Fantastic, and thank you so much to Dr. Beck O'Hara. Please join me in thanking her for her informative and engaging webinar on the management and self-management of endometriosis. I think that there were some really quite shocking insights contained within that research about the diagnostic delay, about experiences of chronic pain, and some of the implications for the management and self-management of this health condition for women and the healthcare system overall. I'd like to thank everyone for attending our webinar today. If you would like more information about our Endo March campaign or of the work of the Victorian Women's Health Services across Victoria, please don't hesitate to reach out to the Health Promotion Officer in your local area. As I mentioned before, Jess Ellsworth from WISE will be circulating an evaluation and the recording of today's webinar to all attendees, so you'll have the opportunity to revisit Beck's research and also submit any questions that you might have via the evaluation. Thank you all for attending and enjoy your afternoon.